Dr. Keyur Shah, Consultant Emergency Physician, Shri Krishna Hospital, Karamsad. Dr. Dhaval Waghela, Consultant Intensivist, Ahmedabad. Dr. Maharshi Pandya, Consultant Intensivist, SMS Medical College, Ahmedabad. Dr. Rajesh Prajapati, Consultant Critical Care Physician, Surat. I invite Dr. Sandeep Deewan to share his knowledge and experience on this topic of acute thrombocytopenia in pregnancy with us. But due to some family emergency, he is not available here, so we have arranged Zoom meeting.
Good morning, everybody. Greetings from Delhi. I'm extremely apologetic that I had to cancel my deliberation physically at your conference at the last moment due to some emergency. In the next 20 minutes, I'll try to do best to the topic allotted to me, which is thrombocytopenia in pregnancy. If you look at the pregnancy as a physiological process, there's data to show that there's always a fall in platelets as the gestation weeks in the pregnancy progress. So if you look at this slide, from 12 weeks onwards, there's a consistently mild decline in the platelets in pregnant patients, and it continues to decline till about 38 to 39 weeks, and then post-delivery, the platelets then come back to the normal range. So it's not that every thrombocytopenia in pregnancy is important, but yes, there's a cutoff level of thrombocytopenia which actually becomes important as it gives risks to the mother as well as to the baby. There can be multiple reasons of thrombocytopenia in pregnancy. It's a very complex topic, but I will try to justify and simplify it in the next 20 minutes. The most common ones can be divided into pregnancy related and not related to pregnancy. Pregnancy related are gestational thrombocytopenia. In fact, gestational thrombocytopenia accounts for 70% of all thrombocytopenias in pregnancy. Preeclampsia, which accounts for the next common cause, helps in 8% of patients, but for all practical reasons and for evaluation purpose, preeclampsia and health syndrome are taken as a common entity. And pregnancy. If you go to non-pregnancy related thrombocytopenia, the most common ones are ITP. As critical care physicians, I'm sure you guys are used to evaluate and monitor ITP, although not very common in pregnancy patients, but it can occur. The other important ones are TTP, HUS. Pseudothrombocytopenia needs to be ruled out before we actually say that it's an acute thrombocytopenia which is relevant. Then we can have thrombocytopenia related with DIC and a whole of other things in the form of vitamin deficiencies, primary bone marrow diseases, infections, antiphospholipid syndrome, which are extremely rare but can happen. On the right side is the list of medications which can cause thrombocytopenia. Among those are antibiotics, diuretics, analgesics, anticonvulsants, and certain miscellaneous drugs, which if prescribed routinely in pregnancy can cause thrombocytopenia, although not a very common cause, but still relevant once you are evaluating a pregnant female for thrombocytopenia. Now, as I said, the causative diagnosis can be huge. It can be very variable. So that's why we'll try to concentrate on the most common ones. And the most common ones are gestational thrombocytopenia. It generally happens because of the accelerated destruction of the platelets or dilution of the platelets because of the increase in the volume of distribution or increase in the total blood volume. Generally presents in the third trimester of pregnancy, may present in the late second trimester also. It's an incidental finding and not actually very significant if the platelet count maintains around more than 70. Less than 1.5 is the cutoff, but if it's more than 70,000, nothing needs to be done for it. But if it's less than 70,000, yes, one needs to keep the patient under monitoring. The other cause I told you was HELP and preeclampsia. These are basically leading to excessive consumption of the platelets, leading to microthrombi. And in HELP, syndrome, you have raised liver enzymes. We all know we have autoimmune hemolytic anemia present in the peripheral smear. It can cause DIC. It can be a manifestation of preeclampsia, and that's why it needs to be properly evaluated, diagnosis made, and we all know the treatment is early delivery of the baby. The next common, as I was telling, is ITP. We all know the mechanism of ITP is because of the immune-mediated destruction of the platelets. There could be a mechanism of suppression of the production also. ITP is generally a diagnosis of exclusion, but it's sometime in pregnancy, it's very difficult to actually differentiate whether it's ITP or gestational thrombocytopenia. So we end up treating ITP also. And the other common, as told, is TTP. We all know TTP has a pentad of manifestation in the form of hemolytic anemia, fever, neurological dysfunction, renal dysfunction, and thrombocytopenia. Unfortunately, if TTP is not treated aggressively in the first 48 hours, it can cause a lot of morbidity and mortality. That's why TTP and HUS are actually to be treated and evaluated aggressively. Pseudothrombocytopenia is basically nothing but clumping of the platelets. I'm sure you would have heard a lot of patients in COVID who came with low platelets after 2 weeks or 3 weeks or 4 weeks. And when we did a peripheral smear, we found that there was clumping of the platelets. So it's exactly not thrombocytopenia. And that's why it's called as pseudothrombocytopenia. And the clumps resolve over a period of time. We'll not go into the other details of thrombocytopenia, but these are the most common ones. Now, how do you evaluate a patient of thrombocytopenia in pregnancy? The first and foremost thing is to do a peripheral blood smear. You send the smear to the hematology department, and the first thing to rule out is the platelet clumping. If there's a clumping, it's artifactual thrombocytopenia. Over a period of time, this will recover. It can be because of certain viral illnesses, post-viral syndromes, but something to be worried about. If there's no clumping and still the platelets are less, it is said to be true thrombocytopenia. And in true thrombocytopenia, then one needs to have a pattern in which one evaluates. If there's presence of schistocytes, and along with that, if there's, we know that the patient has a hemolytic anemia, the patient will end up in a differential of PPS, HUS, DIC. Obviously, the next level of investigations is to do an LDH, haptoglobin levels, PTA, PTT-INR, complete DIC profile, and treat aggressively. We'll go into the treatment protocol of each and every cause, but this is how you evaluate. The other important thing is to then see whether there are any nucleated RBCs or blasts present in the peripheral smear. It is not a common cause, but primary bone marrow disease or bone marrow disorder can be a cause of thrombocytopenia, and the answer lies in bone marrow aspirate and biopsy. In the center, if you see, if there's microspherocytes, clumping, agglutination, there can be Evan syndrome, not a very common cause of thrombocytopenia, but needs evaluation in the form of reticulocytes, LDH, bilirubin. If there's lymphocytosis in the peripheral smear, toxic granulations, neutrophilia, we know it could be because of infection or sepsis. In that case, we need to actually evaluate the patient in the basis of sepsis protocol. And the last will be isolated thrombocytopenia. None of the previous mentioned abnormal cells are present. So we then think about ITP, and we know the most common cause of ITP are viral infections. So the investigations are based on the clinical assessment. So this is how you frame in your mind and how do you evaluate a patient with thrombocytopenia. Now coming specifically to pregnancy, as I told, in pregnancy, normally thrombocytopenia starts from the first trimester or maybe in the second trimester. We have to look for all the causes of thrombocytopenia and divide the patients into two categories. If the platelet lac is more than 1 lakh or the platelet count is less than 80,000. In case it's 1 lakh, one actually keeps these patients under a monthly monitoring of platelets, and every month if there's a continuous fall in the platelet, the patient evaluated as per has been told in the previous slide. If the platelet goes to less than 70,000, There's a risk low neonatal platelet count. So one has to ensure that we do not do traumatic delivery. Sometimes if it's too low, the neonatal cord blood platelets also needs to be checked, because a neonatal thrombocytopenia, although rare, it can happen in patients with maternal thrombocytopenia. If the platelet is already less than 80,000, then it could be related to any of the causes that has been mentioned before. One still needs to go for a monthly monitoring and treat if the platelet count is less than 20 to 30,000. Ideally, the platelet count should be maintained around 50,000 for a potential antenatal procedure in the form of delivery or C-section, and avoid non-steroidal drugs, IM injections, and aspirin. So till 35 to 36 weeks, it's important to keep the platelet more than 80 if possible, because there could be, as I told, potential procedures which will be needed in a maternal, in the mother, in the form of epidural anesthesia, cesarean section, or even delivery. Monitor frequently, document the need for atraumatic delivery, avoid forceps or ventouse or scalps. Ensure you have a pediatrician alert if the patient is thrombocytopenic, and cord sample to assess neonatal platelet count is extremely important. The neonate will need monitoring over the next few days, over the next 5 to 7 days, to look for thrombocytopenia, and it may recover on its own. So this is how you frame the more or less the evaluation of according to the trimester on what should be the cause of thrombocytopenia. Coming to the most common cause, which is gestational, it is generally an incidental finding. The patient does not have any symptoms, so it is defined by 5 criteria. Patient will have mild and asymptomatic thrombocytopenia. There are no symptoms. There is no past history, except during a previous pregnancy. If the patient is a multipara, they may tell that yes, during pregnancy they had a previous pregnancy, they had foreign platelets. Occurs during late gestation. It is not associated with fetal thrombocytopenia, and gestational thrombocytopenia will recover after delivery. But as I told you, it's mild, asymptomatic, but if still the platelet goes to 20 to 30,000, one has to transfuse and maintain platelet count of more than 50,000 for a potential traumatic delivery. That was help and preeclampsia. Depends on which phase of pregnancy the patient is. If the gestational age is less than 34 weeks, it's important that with the low platelet count, we know the early delivery is the answer. So dexamethasone, 10 milligram, 2 to 4 dosages are given. If the platelets continue to deteriorate, we deliver the patient. If it's clinically stable, aim at continuing pregnancy for 2 more weeks to allow for the lung maturity of the fetus to happen. And then preferably monitor the patient in a tertiary care facility where all the methods of evaluating and managing DIC are available. If the gestation weeks is more than 34 weeks, but the platelet is less than 50, dexamethasone again given, and patient is immediately taken up for a delivery. In case the patient has a platelet more than 50 and gestation more than 34 weeks, we can go ahead and deliver the patient. So this is how the management of a thrombocytopenia and help has to be designed. So to summarize a little bit about thrombocytopenia and particularly related to these 3 important causes, HELP, TTP, and fatty liver, if you look at, it's very difficult to differentiate. TTP is a mild, or I would say it's a kind of semi-emergency. And if you look at the differentials, schistocytes are present in HELP and TTP, while they are absent in AFLP. Liver tests are elevated in HELP and AFLP, while they're normal in TTP. And all of them will have thrombocytopenia. So that's why it's important you always have a TTP at the back of the mind, and do not please forget your pentad of TTP. TTP is a clinical diagnosis. TTP will never come in any of the tests. So that is why early plasma exchange to support the mother should be our aim in case the patient comes with neurological dysfunction, renal dysfunction, thrombocytopenia, microangiopathic hemolytic anemia, we should always think of TTP and early plasma exchange should be done. Coming to ITP as a cause, because that's another common cause uh, of thrombocytopenia, although not related to pregnancy. Mild cases can be indistinguishable from gestational. So it's very difficult to differentiate between ITP and others. We have to rule out eclampsia, health syndrome, and other things, as already been mentioned. Treatment is to be indicated only if the platelet goes to less than 10,000, or if the platelet is less than 30,000, but associated with a bleeding. What is the treatment of choice? There is a debate among the treatment of choice in ITP in pregnancy, because steroids ideally are the first line therapy in non-pregnant patients, but they can cause gestational diabetes, fetal toxicity, pregnancy-induced hypertension. That's why there's some group of physicians who say that IVIG should be the treatment of choice rather than steroids. Splenectomy may be done, but only in cases of severe refractory thrombocytopenia, where in spite of IVIG and steroids and other therapies, the patient is not responding. Is there a risk for neonatal thrombocytopenia? Yes, 15% will end up with neonatal thrombocytopenia. So that's why fetal blood sampling is extremely important, and consider cesarean section if fetal platelet is less than 20,000. It's important to design the treatment according to the ITP. Continuing with the ITP, although 70 to 80% of patients, even if given in pregnancy, will respond to steroids. So as I told, it's still a debate. If we can manage pregnancy-induced hypertension and gestational diabetes, I think steroid should be the first level of therapy. Steroids can also lead to premature rupture of membranes, and that's why IVIG comes into play. It's costly as compared to steroids. Steroids are cheap, but if, yes, during managing an ITP with thrombocytopenia, it's always important to weigh the risks versus benefits of each drug. So steroids are cheaper, have their own side effects. IVIG are costly but safer. So there could be a role for first-line therapy for IVIG. Now, there could be a category of patients who will not respond to both. So yes, there is some role to give combination of IVIG and steroids. That could be the third level therapy, or we can go to high dose pulse steroid therapy, which can be 1 gram per day methylprednisolone for 2 days. In case this approach also fails and the platelet does not go up, only in that case there could be a indication for going laparoscopic splenectomy. If it is needed, it should be performed preferably during the mid-second trimester, if possible, to avoid early pregnancy loss and also obstruction of the surgical field by the gravid uterus. So that's why splenectomy is the last resort. If you look at the step-ladder pattern, it should be IVIG, steroids, combination therapy, high-dose steroids, and refractory cases thrombocytopenia. Coming to preeclampsia, 50% of patients with preeclampsia will have thrombocytopenia, and its severity generally parallels to that of the underlying preeclampsia. If the preeclampsia is severe, the thrombocytopenia will be severe. Now, in clinical situations, thrombocytopenia can actually be a manifestation of preeclampsia. So you're not suspecting or diagnosed preeclampsia by the classical diagnostic mechanism of proteinuria or high blood pressure, but you see thrombocytopenia and you start evaluating a patient, and we get to know that yes, this patient has a preeclampsia. So nothing to be done separately. As we have discussed in health, early delivery, early treatment is the way forward to manage the platelets according to the number. TTS, TTP, HUS, I've told you the pentad. Due to the importance of initiating therapy promptly for this disorder, any patient with hemolytic anemia and thrombocytopenia, which is unexplained, should be considered to have TTP. Please keep this in mind. It's not common. That's why we have a tendency to miss it. So this is what we do in the form of treatment. In case you have microangiopathic hemolytic anemias, we go for plasmapheresis, early plasmapheresis. In case one has ITP, we go for prednisolone, IgG, and splenectomy. In case their causes are preeclampsia and health syndrome, we go for magnesium sulfate and early delivery. And in case none of these is evaluated as a cause, we can go for advanced test in the form of antiphospholipid antibodies, ANAs, HIV screening, and other therapies. But the aim is to keep the platelet count at least more than 80,000. And if it goes below that, we have to be aggressively monitoring them and treat the cause. The thrombocytopenia will be treated on its own. And this is what we do in all in our practical practice. So just to summarize, these are the 4 major causes of thrombocytopenia in pregnancy. Please keep them in mind. The incidence varies from patient to patient, but the most common ones is gestational, which is, as I told you, we don't have any clear-cut analysis of the pathophysiology of the disease, but early delivery. ITP, always keep at the back of your mind. Peripheral smears may give you some answers. Preeclampsia, early delivery, HELLP syndrome, treatment, and early delivery. So if you were to all think about management of thrombocytopenia, go by the frequency, have an evaluation plan in mind. We all know that 90% are pregnancy related, 10% may be non-pregnancy related in the form of ITP and GTP. Have a low threshold to evaluate and to treat these drug diseases also. Early delivery, proper planning about the mode of delivery is extremely important. Always keep the neonatal in mind. 15% of them with ITP will end up with neonatal thrombocytopenia. So you have to make a comprehensive plan as a physician on what should be your mode of treatment of thrombocytopenia in pregnancy. With that, I end my deliberation. I'm really thankful to the organizers for giving me the opportunity to speak in front of you. Thank you very much.
Thank you. Thank you very much, Dr. Sandeep Deewan, for delivering excellent lecture on thrombocytopenia in pregnancy. We have mentioned well about the what is thrombocytopenia, what is gestational thrombocytopenia, which is also very common, pseudothrombocytopenia, and other pathological cause of thrombocytopenia, which are either pregnancy related or not pregnancy related or medical cause. And the evaluation of the cause and the treatment is depend on the diagnosis. Thank you very much. Any questions?
Thank you, sir.
Yeah, thank you. So we'll proceed for next session.
I would like to thank our respected chairpersons